first speaker today is my counterpartner, Becky Skinner. She is the diagnostic manager in the Pulmonary Diagnostic and Hyperbaric Medicine. And she is here today to talk about respiratory therapists as COPD educators. So please welcome Becky.
Good morning. So as Lou was saying, I'm going to be talking about how we play a part in COPD education. So I'm going to break up the monotony of saying I have nothing to disclose and actually disclose something. I have an unabashed, creepy love for Bill Clinton. And I actually was invited to meet him 2 years ago, and as you can see, I'm beaming because I can't talk about Bill without going, oh. So it has, well, actually I'll back up. Whoa, what's that? When I got to meet him, I admit I actually did lean in a little close to smell him, and he does smell amazing. So my love for him and admiration has nothing to do with politics. It definitely does not have to do with his questionable sweaters. I love him because he is charismatic and probably one of the top extemporaneous speakers of all time. And what I'm disclosing is I am no Bill Clinton. So the reason why I'm up here is because I'm very passionate about patient education and the work we've started doing, and I'm extremely proud of our COPD educators and how much dedication and commitment they've had to this, so thank you. So the objectives are to talk about some of the challenges of providing care for patients with COPD, and many of the challenges that I'm really going to hone in on have to do in even diagnosing it and in patient education. Review a little bit about the hospital readmission reduction program and to talk about our newly implemented COPD initiative. So first, let's just define COPD. As we know, it's a chronic obstructive pulmonary disease that's common, preventable, and a treatable disease characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities, and it's usually caused by a significant exposure to some noxious particles of gas. It is diagnosed by evaluating signs and symptoms such as dyspnea, chronic cough, increased sputum production, that history to some type of lung irritant, a family history, and spirometry is the only definitive test that can be done to actually meet that airflow limitation part of the diagnosis. So not getting spirometry when you're diagnosing COPD is a lot like diagnosing somebody with hypertension and never have gotten a blood pressure. So as we know, it has a global prevalence of 11.7% and is a leading cause of morbidity and mortality in the United States with over 12.7 million people diagnosed, which costs our nation over $52 billion annually in either direct or indirect costs. And there are an estimated 13 million more that are undiagnosed. As these two graphs kind of depict the prevalence of how often COPD is a leading cause of hospitalizations and ED visits, as you notice, some of these other conditions that also have a high prevalence of it have already been on the health or hospital readmission reduction program, which I'm going to talk about next. So what this is there are provisions in the CMS hospital readmission reduction program that place increased pressure on hospitals to integrate with all kinds of healthcare systems. In 2015, COPD was included to this, and basically it penalizes hospitals up to 3% of Medicare payments for excessive 30-day readmissions when compared to expected levels of readmissions. And COPD was added to the already diagnoses on this program of heart attack, heart failure, pneumonia, and hip knee replacement. And as you saw on the previous slide, COPD was actually higher than a lot of those, so it's actually surprising that it didn't just start off on that initially. There is a serious flaw in this program in that it penalizes hospitals for unrelated readmissions, so it's an all cause. So basically, if you're in the hospital for COPD exacerbation, get discharged, and 15 days later, you cross the street and you weren't paying attention, get smacked by a bus, obviously that has nothing to do with the care that you received for COPD, but in theory it could be dinged. So while that program is definitely not perfect, the whole intention is to bring important stakeholders together to focus on value-based care for patients with these kinds of conditions. And it seeks to reduce costs, prevent hospital readmissions, increase patient education, and self-management, which is very key. So just diagnosing COPD poses its own set of challenges. The first clinical practice guidelines were published about 30 years ago. And these originals were issued by professional societies and other groups, and they were consensus recommendations, not based on, or it was based more on expert opinion and available studies, and they were largely criticized because they were not explicitly evidence-based, and we hear a lot about evidence-based medicine anymore. And so that's kind of a reason why they weren't really followed. However, in 2001, the Global Initiative for Obstructive Lung Disease, GOLD, which you'll hear a lot about, the National Heart, Lung, and Blood Institute, as well as the World Health Organization, all released the first set of a new generation of rigorous evidence-based practice guidelines. So while these previous guidelines had differed in severity grading systems and differed in therapy recommendations, these newer guidelines are very consistent and have very few areas of relevant clinical discrepancies. So although these newer guidelines have both international authorship and they're intended for worldwide use, implementation of many of their recommendations has been very slow, such as the requirement of spirometry in diagnosing and staging. And providers are still either just unaware of them or are not using them. And this presents a lot of challenges. Primary care providers are obviously the ones who care for the majority of COPD patients. And only 55% of them have reported to actually be aware of evidence-based practice guidelines, and of that 55%, only 25% of them actually use them. So there's a very small percentage of primary care providers that are either aware of them or just don't use them, or actually use them. So they estimate 30 to 50% of patients diagnosed with COPD have not had spirometry, and that leads to a lot of problems such as inappropriate drug prescriptions that come to risk for patients. It obviously causes a financial burden to patients as well as the healthcare system, and it delays treating other possible causes for their symptoms. So this does have a big impact, and this is an interesting study. In 2017, data was gathered from patients admitted to hospitals with COPD as a leading diagnosis for their respiratory symptoms. Of the 6,018 patients included in the study, 21% did have confirmatory spirometry prior to admission. 8.4% were further given spirometry during hospitalization. And of those with valid spirometry, 69% did confirm, yep, it's COPD. 27% actually had restrictive lung disease, and 4% were normal. So of those patients that they did hospital spirometry on, where COPD was not indicated, 43% were still sent home with a diagnosis of COPD on their discharge summaries. 26% were sent home on oral steroids, and 31% sent home on maintenance inhalers commonly used to treat COPD. So even when a patient who had a previous empirical diagnosis of COPD was found not to have it, they continue to carry that diagnosis around and be treated for it. And our own Dr. Fortis has done a similar study to this, and he found the exact same thing on the outpatient side. It's like once you're tagged with that, you can't get rid of it. 1 out of 3 patients admitted to a hospital with a diagnosis of COPD may be misdiagnosed and mistreated. Obesity, sleep apnea, hypertension, coronary artery disease, and congestive heart failure were strongly associated with comorbidity attributed to this misdiagnosis. So why isn't spirometry being used? Well, there is a belief that it's difficult to perform in hospitalized patients. That's false. In those that were given spirometry during hospitalization, 88% of them did it just fine and met ATS criteria. So that isn't a good reason not to get it. It can wait till after discharge. We hear that a lot too. Wrong. Spirometry done 1 month after discharge from a hospital was found not to result in any significant change in the overall diagnosis. And the bigger problem with waiting till discharge is a lot of those patients will be lost to follow-up and will never have appropriate testing done and continue to get treated with stuff they probably don't need. I'm sure it was already done because they came in and said they had it. Again, we don't know if they actually had spirometry or their provider just assumed they had COPD, and so that's what they report on admission as part of their history. I don't know how to read the stupid things. That's true, and this actually came from a physician who admitted that. I know COPD when I see it. Well, apparently we don't. We already talked about guidelines, how they aren't followed. And, well, the patient's a smoker and short of breath. I don't need spirometry to tell me he has COPD. Well, the problem with that is less than 50% of smokers actually develop COPD. So we can't rely on just the old theories that we have. So clearly these are challenges in care in just diagnosing it appropriately. So now let's assume patients that got diagnosed actually do have it. So when a patient receives a diagnosis, or whenever we go to a doctor's office and get told we have something, we assume that they're going to educate us, right? Well, if that was happening, why are so many patients either uninformed or misinformed? A lot of the answers go back to COPD patients are diagnosed and managed largely by primary care providers, and they generally lack expertise in COPD. They have to know a little bit about everything, so you can't really be an expert on different diseases. In this study that I'm going to talk about, this was actually in the Respiratory Care Journal this past March, and it basically was a survey administered to people that had COPD. Of the participants, 82% claimed to really understand their disease and available treatments. Yet, COPD symptoms and causes were well known to only 45% and 44% of those, respectively. So they understand it. Why don't they know what caused it or what the symptoms are? Also, 35% said they were knowledgeable about medications. That's pretty low. And 27% were even aware of the importance of preventing their symptoms. So there clearly is a big disconnect between what patients think they know and what they actually do know when you drill down. And I can personally relate to this, and this is a lot of how this really started for me, is I was sitting across the table from my uncle who has a lot of heart issues and severe asthmatic as well as has emphysema. And he was just wheezing, his color was getting all dusky, and I'm like, did you take your inhalers this morning? Well, yeah, I take them every morning. And I'm looking at my watch, and I was like, well, I think you ought to take a rescue inhaler. And he looks at me like, what's that? And I'm like, albuterol, do you have your albuterol on you? He's like, well, yeah, but I wheeze like this all the time. No big deal. And I'm like, well, you shouldn't if your symptoms are actually under control. And it took a while to convince him, and then my aunt and mom started nagging him to listen to me. So he's like, fine, gets it out, sprays his face. And I'm like, it's no wonder your symptoms are under control. You bronchodilated your face. And I'm like, who taught you how to do that? And he goes, oh, well, I've been taught by so many different people over the years. This is just what I've stuck with. So it is very difficult to, or I should say it's very easy to teach somebody the correct way the first time than teach somebody the correct way after they've been doing it incorrectly. That is a lot more difficult and challenging. So we need to make sure they're getting taught the very first time. So where education starts, this top chart shows what topics were discussed during a patient's very first office visit. You'll notice not a single topic even reaches 60%. Less than 50% of these patients have been told what